Perfect, thank you. Just to check you can hear me properly now. Yeah, brilliant. Okay,
yes,
thank you. Thank you. Thanks for inviting me, and lovely to see you all. There's some names that I recognise, so that's really nice. So as Tamara said, this talk is about personalised care and support planning in dementia. And I'm going to start the talk with a bit of an introduction to the concept of personalised care and support planning, and then talk about two Alzheimer's Society funded research projects that I've been involved in, where the focus has been post-diagnostic personalised dementia care led by primary care. And when I talk about primary care today, I mean the patient's first point of care, for instance, GP practices or surgeries, as opposed to secondary care, for instance, hospitals. So I thought I'd start, though, by saying a bit about my background and the wiggly pathway I've had into dementia research. So I've got a clinical background in speech and language therapy, which is actually an underrepresented profession in academia. And because of this, I feel like I bring quite a distinctive perspective on communication in dementia care research. I was also a lecturer in speech and language therapy for 14 years, during which time I completed a PhD looking at everyday conversations in Parkinson's and how best to support those. And I got really interested in dementia and took over some teaching relating to this. And that's what led me to a research fellow post at Plymouth University, which was about developing and evaluating a dementia support worker intervention. And then I moved to University College London as a study manager for the PRIDEM project, which I'll talk about shortly. So I'm really enjoying my work as a dementia researcher now. Okay, so what is personalised dementia care planning? To start with, the social psychologist and pioneer of dementia care, Tom Kitwood, he laid the foundations for talking about person-centred dementia care in his book Dementia Reconsidered, written in 1997. And he set out a philosophy which valued personhood and identity above all else. And here's some nice quotes from his work. Personhood is a standing or status that's bestowed upon one human being by others in the context of relationship and social being. Dementia doesn't take away personhood, so core to this is the importance of relationships and communication. And these quotes will become more relevant as I go through this talk. So the concept of personalised care has made its way into policies and has really built on those person-centred principles that I've just spoken about. The World Alzheimer's Report in 2022 and NHS England, they both position personalised care and support planning as a core element of post-diagnostic dementia care, based on conversations about what matters most to people, taking into account their life situations. And people with dementia should have a personalised care and support plan outlining their unique care and support needs and how they'll be addressed, and also their strengths or what's going well and how these can be maintained. But despite these ambitions, routine dementia care planning in primary care is often quite inconsistent. The Quality and Outcomes Framework is an incentive programme in the UK, rewarding GP practices for providing high quality care, and requires annual dementia reviews as a way of delivering personalised care planning. But there's a lot of variation in the quality and delivery of these reviews, as I'm sure people here know. So the first project I'm going to talk about is PRIDEM, which ran from 2018 to 2023. And this was about developing and evaluating an approach to post-diagnostic dementia care led by primary care. It's funded by the Alzheimer's Society, and the overall programme of work was led by Newcastle University, with the evaluation being carried out at University College London. So just as an introduction to PRIDEM and a bit of background, so post-diagnostic dementia care has traditionally been based in specialist-led services, for instance, in hospitals. And this way of doing things has been recognised as inadequate, poorly coordinated, and also financially unsustainable. There's been a lot of international policy and research that's emphasised the urgent need for better coordinated dementia care led by primary care. And it's been long thought that this shift has the potential to use existing resources a lot more efficiently to improve timely and tailored access to specialist and community support, and ultimately enhance quality of life for people with dementia and their carers. But there are lots of challenges in terms of workload capacity and also a lack of specialist knowledge of dementia in primary care. So the PRIDEM project aimed to both develop and test a primary care lab model of post-diagnostic dementia support, and then evaluate whether that model is feasible and sustainable for primary care to implement in the long term. So developing the PRIDEM approach took place in the early years of the programme and involved evaluating current ways of delivering dementia care, so looking into existing evidence, identifying components of good practice in post-diagnostic dementia care, and using the knowledge from these two work streams, developing an evidence-based approach for primary care-led post-diagnostic support. And throughout, the group called the Dementia Care Community, which was a group of people with dementia, informal carers, and health and social care practitioners, gave input and perspectives throughout to help guide this process. So to simplify the approach that was developed, the approach was that primary care staff, so GPs and GP practice staff, would provide day-to-day dementia support rather than specialists based in hospitals. And clinical dementia leads would be introduced into primary care who had expertise in dementia, and they would support GP practice teams to improve and strengthen their dementia care systems. And they would do this in three main ways. So if we go round this circular diagram, they would work with staff to train them about dementia and the type of support that's available, develop better ways to provide dementia support, and make sure support is personalised. In other words, addresses what matters most to people. So this intervention, we'll call it an intervention from now on, this was to be practice-led rather than clinical dementia leads coming in and doing all the dementia care and support. So it was about empowering practices to improve their own systems of dementia care. So how was this tested out? So 2 clinical dementia leads worked with 7 GP practices in the southeast and northeast of England. They delivered this approach or intervention over 12 months. We had advertised the role as suitable for a range of professionals with dementia experience, but as it turned out, 2 nurses were appointed to roles, 1 for each region, and they received clinical supervision from a highly specialised senior dementia nurse. They were also given kind of bespoke training that was developed by the research team, and a practice manual as well to work from. So also during the 12 months of the intervention and afterwards, we interviewed healthcare professionals, people with dementia and their carers who were linked to the participating GP surgeries to find out more about their experiences of the PRIDEM approach as it was happening. Ooh. Sorry, got ahead of myself there. And we also carried out an audit of how many people with dementia and their carers had their support needs reviewed annually, and a personalised care created within their care records in the participating practices. So to start with, we saw some quite encouraging day-to-day changes achieved in some of the practices. And these were where the clinical dementia leads had identified and enlisted enthusiastic dementia champions. For example, some of the care coordinators or junior GPs really took this on and created sort of small dementia practice teams to plan innovations. So some of the changes that happened were some of the practices changed the systems for annual dementia reviews, and I'll come on to that in a minute. Some of the practices became a lot more dementia inclusive, so they improved their signage and had information stands, which they updated. The clinical dementia leads delivered some formal and informal training to a range of staff, all levels of staff, from receptionists to GPs. They did some joint home visits with a variety of staff to help advise, especially on complex cases. And the CDLs also carried out a mapping exercise of what was available locally and nationally to support people with dementia in a range of different areas, from all the way from continence services to memory cafes to support for young onset dementia and so on. And from this, they created a comprehensive directory for GPs and other practitioners that they could easily use for referring people for tailored care and support, something that they hadn't really had before. And work to empower GPs and other practitioners to feel that they knew what to do. So coming back to the audit that we did an audit of electronic patient records, and we compared a pre-intervention year, and that happened to also be a pre-COVID year to make it a more typical year. We compared that with a post-intervention year. We weren't comparing the same people, but taking a random sample from each year. We looked for the presence or absence of a personalised care plan in the notes. And we also looked at to what degree the care plan was personalised and also what was discussed. You can see on the right the criteria we used to describe personalisation, which we developed with members of our dementia care community, and also using criteria that had been outlined by NHS England. And all of these elements we considered necessary and valuable for personalisation, and we collected their presence or absence in our audit. But the minimum requirement that we took to be deemed as personalised was that the person with dementia was present in the conversation. And on the bottom of that list, you can see that we also looked at domains of care and support that were recorded in the notes to look at kind of the breadth and holistic nature of the conversations that were had. So the headline news, and this is taken from our infographic that I'll share a link with you in a minute. So the headline news was that before the PRIDEM approach, only 1/3 of people in the practices were benefiting from personalised care planning. But after the PRIDEM approach, this increased to almost 2/3 of people. And within completed care plans, there were marked changes in indicators of personalisation. So, for example, recording outcomes or goals and planned actions increased, and evidence of outcomes being agreed with the person with dementia and or carer more than tripled. There were also some observed changes in the areas of care and support that were covered in care planning conversations, which suggests a move towards more holistic care planning. So, for example, pre-intervention, only 2% of care plans addressed activities and interests of the person with dementia, whereas post-intervention, 40% of care plans covered this area. And here's some findings from the PRIDEM interviews. So despite the pressures in primary care, most practices made changes to annual review and care planning systems. So, for example, a couple of practices set up one-stop shop dementia review clinics. This is where several people with dementia and carers would attend on the same day for their reviews and meet members of the multidisciplinary team, not just the GP, but people like the dementia advisor and the practice nurse, for instance, as well as meeting some supporters that came in from Age UK. They also, of course, got a chance to meet each other for some peer support. And at the same time as the dementia review visit, they would have all their physical needs addressed, for instance, the diabetes checks and vaccinations. And one of our GPs in the interview said, a lot of patients have felt neglected in the last 2 years. Proactively reaching them and offering them such a comprehensive review has regained some of their trust in us. And she was talking about the COVID years. So another thing that people reported on was that some of the resources that the research team had created to support dementia reviews and care planning had been used and had been adapted to fit the needs of the practice, which was always the aim, that any resources would be kind of flexible and adapted. And then clinical dementia leads were reported to have helped staff to really improve their knowledge of local and national dementia services. So there were some really positive findings. And then we also found that there were some other positive and longer lasting effects. So a lot of staff reported feeling more confident and knowledgeable about supporting people with dementia and carers. Majority of people with dementia and carers found attending an annual dementia review helpful. So this person with dementia said, I went away very well satisfied from this thing that I'd never been to before. I thought it was a great success. I hope they'll do it every year from now on. Some people noticed that their practice had become more dementia inclusive. So this carer said, the receptionist or whoever it is who's answered the phone, they seem to have improved from what they were before. And there were some sort of changes sustained beyond the project lifetime. So some of the one-stop shop dementia review clinics are still going on to this day, several times a year. And some sort of mapping resources that had been developed by the clinical dementia leads. Their directories of national and local services are still being used. And the last we knew, there were some talks about who could help to update those on a regular basis, with social prescribing team being the team that was identified to do that, to keep them up to date and relevant. So although there was some improvements shown in care planning, some areas of care saw less change in representation. A clinical dementia lead, overall a clinical dementia lead working with general practices to improve dementia care systems seems to have potential, but these are the main challenges. The first one is due to capacity and workload issues. The flexibility of the approach led to some teams using the clinical dementia leads just as an extra pair of hands, which is understandable, but also limited their ability to influence change. And also some areas of care planning that saw less change in representation within care plans were medication reviews and end-of-life planning. So given the need to minimize the risks of taking multiple medications or polypharmacy, and also the challenges of timing end-of-life discussions, we felt that future versions of the intervention could target those specific areas, perhaps through clinical dementia leads providing staff training. And some instances, people with dementia and carers said they'd had a good experience, but follow-up after review was lacking. So this is another area to be improved. So in terms of the PRIDEM project, there are lots of information and resources that we've produced, and I'm going to share these slides after today, so you'll be able to have a look at those. There's some information about the whole project on the Alzheimer's Society website. We produced an infographic summarizing the results of the interview studies. We've created some animations for different target audiences. One is for people with dementia and carers, and one is for practitioners and commissioners. And there's a more detailed study report for practitioners and commissioners as well. So you'll have all the links to those if you want to find out more. So I'm just going to talk probably a bit more quickly now about the CAPT project. So this is my own 3-year project, inspired by my experiences of working on PRIDEM and also my interest in communication. So CAPT is communication aspects of personalised care planning in dementia. And I'm just entering the 3rd of 3 years of this project. So I'll give you a bit of a background to this one. So I mentioned earlier that NHS England recommends that care planning is achieved through personalised conversations, focusing on what matters to people. But there's a distinct lack of detail for practitioners on how to have these conversations. A lot of information on what the conversation should cover, but how to actually have them, how to facilitate the conversations is kind of missing. Also, due to pressures on GP workload, NHS England is encouraging wider team involvement in personalised care planning, including roles such as social prescribers, care coordinators, and dementia advisors, as well as others. And while these non-clinical practitioners already provide personalised strength-based support, they often operate really separately from GP-led annual dementia reviews. Another difficulty is that many of these practitioners lack confidence in having these personalised care planning conversations, especially given the communication difficulties associated with dementia, and often end up just talking with carers. There's a real lack of training focusing in on the communication aspects of doing personalised care planning conversations, which is what I'm interested in. And when I talk about personalised care planning conversations for the purposes of my study, I mean that really broadly in terms of having conversations with people with dementia and their carers about to identify kind of what matters to them, what their support and care needs are, and how they might be addressed. So the aim of the CAPT project is to develop a training and guidance toolkit of communication strategies for the wider primary care workforce. And this will support them to facilitate care planning conversations and work alongside GPs to provide holistic and timely personalised care. So these are the different work streams that I've been working on so far, and I'll just explain where I'm up to with this project. So I started by reviewing the research and published a summary of it. There's a link on the bottom here to that work. So there's a general agreement that effective dementia care and support requires both practical communication techniques, like addressing the person by name, avoiding recall questions, and paying attention to nonverbal communication, as well as genuine emotional connection, which is really helpful to know that those sorts of things are agreed upon. But existing research focuses very much on care home settings and people with more advanced dementia. And there's a real lack of evidence of effective communication strategies for personalised care delivery in primary care. So further work I've done to investigate this is interview 11 people with dementia, 13 carers and 19 practitioners about their experiences of care planning conversations, what seems to go well in terms of communication practices, where could things be improved, where the gaps are, and so on. I finished and analysed those interviews now, so I'm going to give you a bit of a summary of the findings of those in a minute. I've also collected 6.5 hours of video data of actual real-life care planning conversations between non-clinical staff members and people with dementia, plus or minus a carer. And that's really interesting because in interviews, people can tell you what they think happened, but in videos, you can sort of see what happens and identify where the strengths are and where there are opportunities for further training. So I'm currently analysing those videos at the moment. And then findings from all these 3 previous work streams are currently feeding in to some workshops where researchers, people with dementia, carers and practitioners are all getting together to use these findings to create some kind of training toolkit together. So it's a very exciting stage of the project. So I said I would give you kind of a brief overview of the interview findings. And I'm about to submit these for publication, so I'll be able to send a link or details if and when they're published. I've developed 3 themes that tell the story of the interview data, and these broaden out from theme 1, which looks at the micro aspects of communication in terms of what is said and how. So I've called that beyond the tick box, and you'll see why in a minute. To theme 2, which looks at the relational dynamics between the people in the room, often the practitioner, person with dementia and carer. I've called that balancing voices in the conversation. And then to theme 3, which looks more at the organisational context in which practitioners sit and its impact on the conversation. I've called that From Silos to Meaningful Shared Care Planning, and you'll see why in a minute. So just to give you an overview of theme 1, this theme sits at the micro level of the figure that I just showed, what actually happens in the conversation. So in the interviews, what I found is that practitioners often rely on checklist-driven approaches, going through standard yes-no questions, and everybody feels that limits connection and personalization. So it's not just people with dementia and carers that feel that, practitioners themselves feel like that. And all participants felt like meaningful conversations happened when both sides had time and preparation to understand the purpose of the conversation, and when communication adaptations are adopted to support communication, for example, visual resources to support comprehension, when cultural humility was shown, for instance, learning a greeting in someone's first language, and when people with dementia had space to tell their story. So when practitioners had time to slow down, listen, and adapt communication, conversations themselves became quite therapeutic. People felt reassured, understood, and more willing to disclose difficulties in conversations. And then, so conversations became not just a vehicle for care planning, but an intervention in their own right, a part of the actual care. And here's a quote from a person with dementia. "It was an entire tick box exercise whereby it was merely yes or no. And even if it was a no, it wouldn't have made any difference. There was no follow-on from the no." So theme 2 sits at the in-between level, the relational dynamics between people with dementia, carers and practitioners. Time pressures and inaccessible formats often lead practitioners to rely on carers, unintentionally sidelining a person with dementia. And carers describe the emotional pressure of speaking for someone else and worrying about getting it wrong. Skilled practice involved actively structuring conversations so that both voices could be heard, sometimes through separate discussions. But balancing voices isn't automatic. It requires lots of time, confidence, and training. And here's a quote from a carer. "On the phone, you're having to be really careful because it's my interpretation of what's going on. It's not necessarily correct, is it?" And finally, theme 3 focuses on the wider system. It shows how hopes for personalised dementia care are often undermined by a fragmented and poorly connected system. So the word silos in this context means different services operating really separately and not talking to each other or collaborating effectively. The dementia care often feels quite fragmented and confusing. People with dementia carers and practitioners described a system that feels disjointed, with lots of different services that don't seem to talk to each other. And this leaves people unsure who is responsible for what and where to turn to for help. Poor communication makes people feel lost and unsupported. So gaps in communication mean people don't understand their care, who's involved, or what a care plan is. Many had never seen a care plan or been clearly involved in creating one. Many practitioners had the same confusion about the purpose and ownership of care plans as people with dementia and carers. Non-clinical practitioners, like the social prescribers, the dementia advisors, the care coordinators, had the time and capacity to do care planning conversations really well, but often didn't have the support or recognition to do so. So these sorts of roles frequently became the default main point of contact for families. They have the time to build trust and to engage in meaningful conversations, but this work is often really informal, maybe unrecognized, and also quite emotionally demanding. Services, like I say, were seen to work in parallel rather than together. And even when practitioners could see each other's notes, they rarely had time to talk and think together. This means that care plans continue being tick box exercises rather than living, shared guides that reflect changing needs. And then finally, it was shown that better conversation and coordination could transform care. So when teams had time to talk, when they shared systems and had clearer roles, care felt more joined up and more person-centered. So these findings show that meaningful care planning depends not just on forms and systems, but on real conversations between professionals and with people with dementia and their carers. So here's a nice quote from a social prescriber expressing her wishes for how things could be. Social prescribers have time. I'd like us to be more connected to clinicians. Our job is to make their job better. We sit and talk. Most doctors would love that luxury. If they guide us on what they want, what do you want us to do? What are you trying to achieve here? Getting it nailed what this care plan is supposed to achieve. So overall, the interview study exposes a persistent gap between policy ambitions for personalised dementia care and practice. The time-poor, checklist-driven encounters and fragmented systems undermine the trust-building conversations that people with dementia rely on to disclose strengths and difficulties and participate in shared decisions. Whilst NHS dementia training standards do define communication as a core competency, these findings from these interviews suggest this is not yet consistently embedded in workforce training or realised in everyday practice. So as I said, I've also been collecting some video observations of real life care planning conversations between non-clinical primary care practitioners and people with dementia and their carers. And here are just a couple of stills from those lovely conversations that I've been observing. As I say, I'm still analysing these, but findings will feed into the training toolkit that's currently being developed. But these are some of my observation insights so far. I've noted some potential strengths from the conversations that are happening, but also some potential areas for training. In the conversations I've recorded, there is a lot of providing reassurance, which is something that is very much valued by people with dementia and carers. There's some evidence of working together to jointly solve problems and work out what would work best for people. And there's a bit of what I've called normalizing the use of strategy. So when suggesting, say, some memory strategies, saying things like, oh, you know, I had another chap who did so-and-so to help him remember. And then some of the potential areas which might be included in the training toolkit are things like preparing for the conversation better. So making sure that everyone understands the role of the practitioner and the purpose of the meeting, working hard to set expectations at the beginning, and including agreeing strategies for ensuring that people with dementia and carers are both heard during the conversation. So another big potential area is how to ask questions. So I'm using a method of analysis called conversation analysis, and I'm looking really carefully at the questions that I use and how they could maybe be formatted a bit better. I think a lot of practitioners know they should be asking some open questions, but sometimes these go a bit wrong. So for instance, asking how have you been going in the last year is a bit too long of a time frame for the person with dementia to know what it is exactly that's being asked about. Or sometimes questions are asked that are more like statements and hint towards expecting a no problem type of response, like, so you're sleeping okay, you're managing to get out and about. So it's not so much opening up the possibility for things to be going wrong. There are some missed opportunities to kind of delve deeper into what's going on at times. And I think practitioners have said already that they would really value some training in how to use visual resources to support these sorts of conversations. So I can see some great potential in doing that. So those are just some thoughts on the observations so far. And I just thought I'd add a final thought. There's some research by Lowe and colleagues who conducted a review of care planning for community dwelling people with dementia. And they found that there's a lack of robust evidence that having a care plan alone results in measurable benefits for people with dementia or their caregivers. And This just makes me think that maybe that's because there's much more to it than an actual care plan. It brings us back to the point about the power of conversation as an intervention in its own right. And for that to happen, everyone in the conversation needs to know why they're there in the room having the conversation, and there needs to be genuine connection between people. So moving away from a purely procedural task and moving much more towards building genuine partnerships. So thank you very much for listening. I'd be really interested in hearing your questions and thoughts, and do email me if you'd like to get in touch.